Good morning, good afternoon, good evening, ladies and gentlemen, wherever you are. I am Paola Barbarino, the CEO of Alzheimer's Disease International. It's my pleasure to welcome you to this webinar, the second in the series stemming out of the publication of the World Alzheimer Report 2021. And this webinar in particular will be on innovations in diagnosis and diagnostics. Next slide, please. Next slide, please. I am going to give you a brief introduction to ADI. For those of you that don't know, there is 600 of you online today from 96 countries. Thank you for coming. We were established in 1984. We are the umbrella organization of Alzheimer's and Dementia Association around the world. We have 105 full members, 20 other members in development. That's one member per country. And we represent all of you at the WHO, at the UN, OECD, and other bodies. We promote World Alzheimer's Month. We publish the World Alzheimer Report, and our vision is prevention, care, and inclusion today, and cure tomorrow. Now, before I start telling you about the webinar, can I please remind you that the webinar is going to be published online within 24 hours from this recording. So you will be able to access it at leisure following the webinar. You can introduce yourself on the chat line as we normally do, but for your Q&A, please use the Q&A box, and we will try and take as many questions at the end as possible. I am also going today to remind you that our global conference is going to be in London next year, 2022, June, and you're very welcome to come either virtually or in presence. It's going to be a hybrid, but in particular, I want to remind you that the abstracts are open, and please submit your abstract as soon as possible. Thank you. Next slide, please. World Alzheimer's Month is finished. The tagline was no Alzheimer's, no dementia, but that's not a good reason not to continue to tell people that they need to know Alzheimer and no dementia. So please continue to interact with our social media accounts and spread the voice of all the work we do, not just World Alzheimer's Month. Next slide, please. A brief thank to our sponsor, which I will not name, but you can see their name, and all of whom allow us to continue to be so effective as an organization. Next slide, please. And reminding you that we are a charity. If any of you feel so inclined, we welcome and are grateful for every donation that comes our way. ADI is a charitable organization, and we cannot do what we do without your generosity. Thank you. Next slide, please. And now it is my pleasure to introduce you briefly to the speakers today with me, Professor Pedro Rosaneto, Sasha Boveat, Gill Farrar, Dr. Emily Largent, Professor Zoe Kourtzi, Kate Swaffer, and Dr. Linda Sommerlade. I will give you more of an introduction to them as they come into the limelight and speak. Next slide, please. Now, let me tell you a little bit about the report. So, as you may remember, the area 4 in the Global Action Plan on Dementia is dementia diagnosis, treatment, care, and support. The WHO target is that at least 50% of countries, as a minimum, 50% of the estimated number of people with dementia should be diagnosed by 2025. Now, the report really drilled into this number and tried to understand exactly what's happening in higher and lower middle income countries. And I strongly recommend you read the report because there's so much detail. Next slide, please. However, I'm going to give you just some headlines. So McGill was the wonderful university that did the report. Pedro from McGill today is with us and will deliver a lecture on the report. And the report focuses on the global perspective on the current dementia diagnosis practices, barriers, and facilitators. Next slide, please. Next slide, please. The report is a journey, as we said, and includes expert essays. It includes surveys, and it includes specific testimonies. So it's a very technical report, but it also has a lot of lived-in experience. Next slide, please. The report contains survey data from 3,431 respondents, and they were clinicians, people living with dementia, and Alzheimer's and Dementia Association from around the world. Next slide, please. Now, some infographics from the report. The rates of undiagnosis are high. I just want to draw your attention to the left-hand side infographic. Globally, we estimate that 75 million people living with dementia are currently not diagnosed, and that makes for 41 million people globally not being diagnosed. The rates of underdiagnosis are inversely related to the income of countries, from around 60% in higher income countries to above 90% in lower income countries. There is a lot of inequality in diagnosis. And now I'm going to ask Jane to pass to the next slide. What really came very, very strongly from the report is that healthcare system around the world are simply not prepared. We need to do more, and we need to do more now. In addition to that, during the month of September, we came public with what is now becoming a big issue, and that is that there is a link between COVID-19 and cognitive deterioration. So this is not going to get any better. There's going to be more and more diagnoses. Health systems really need to be prepared. Governments need to do something now around diagnosis. This is why we published the report. Next slide, please. Some recommendations from the report. Clinicians must become aware and better informed about information, support and planning that is available by a National Alzheimer and Dementia Association, because it's too often that people are given a diagnosis and no information about what is going to happen next. And that's terrible. People need to know, need to be given the comfort of having an idea of what's going to happen to them. Healthcare system globally should introduce annual brain health checkups for the over 50s. And this should be facilitated eventually by evolution in biomarker science, of which we'll hear more today. The government must be prepared for a tsunami of demand for healthcare services, which is going to come. And putting your head in the sand is not going to solve the problem, certainly not now. And four, best practice in assessment must be recognized as a combination of cognitive testing backed up by scan and or CSF testing, plus preparedness and readiness to embrace emerging biomarkers, all of which, as the report says, is a little bit broken pretty much all over the world. Next slide, please. The full list of recommendations can be found at the report. I cannot stress enough how complex and rich this report is and how important it is that you take it on board seriously and also possibly push it to your government as much as you can. So now I'm going to end here, and I am going to introduce you to Professor Pedro Rosaneto, one of the main contributors of the report, the director of McGill University's Research Center for Studies in Aging. And Pedro, the floor is yours. Welcome.
Thank you so much for the kind introduction. Hello, everyone. And thank you for the opportunity to share my impressions here in this webinar. So first slide, please. Okay. So dementia is a clinical diagnosis that results for a number of long-standing disease processes in the brain. These diseases may either affect the brain circulation, preventing the arrival of nutrients and oxygen to the brain, or they can be a result of proteins that, instead of being eliminated by the brain, accumulate, reaching toxic levels of both processes. In fact, disease processes such as Alzheimer's disease and cerebrovascular disease typically have a long silent phase where the disease develops without symptoms. Therefore, it has been accepted that one can prevent dementia by halting the disease process before the emergence of the dementia symptoms. Next slide, please. Brain scans and labs are important. Brain scans and labs are important because they help physicians to rule out treatable cases of dementia. For example, brain tumors or other metabolic diseases can be examples of disease that can be preventable. However, biomarkers, they can reveal the causes of underlying dementia. Scientists, in fact, that have been working very hard to develop tests to develop the underlying causes of dementia at very early stages. And today, There are biomarkers to diagnose Alzheimer's disease many years before the onset of Alzheimer's disease dementia. Biomarkers are therefore tests that use scans, spinal taps, or blood samples and are capable to detect ongoing brain diseases at very early stages. The absence of therapies in biomarkers reduced the utility of the clinical utility of biomarkers for patients presenting early onset dementia or atypical dementias. With the advent of disease-modifying therapies, biomarkers will be needed to ascertain therapeutic indications of these therapies. Thus, early detection by biomarkers bring the hope of early therapies able to stop the diseases that cause dementia. Next slide, please. So there are several types of biomarkers. Imaging biomarkers, they require PET scans, cyclotrons. They are expensive and not readily accessible or affordable to most healthcare systems worldwide due to the problematic of accessibility and prices. Cerebral fluid biomarkers, they are affordable, but they require a complex procedure to remove cerebrospinal fluid from patients. And the recent developments on biomarker allow the dementing disease to be diagnosed by a simple blood sample. Blood biomarkers now show diagnostic promise, giving their practicality and scalability. They bring the hope for early diagnosis, large-scale trials in early interventions designed to stop the progression of dementia in the brain. One of the most important critiques for the use of biomarkers in clinical care regards their cost and lack of the disease-modifying interventions. Next slide, please. Clinicians foresee an increase of the number of patients seeking dementia diagnosis and expect that biomarkers will help them to diagnose the underlying causes of dementia. With these prospects of disease, prospects of disease-modifying interventions, there will be a need of biomarkers at large scale. Next slide, please. Although growing in clinical applications, biomarkers are far from the reality of the vast majority of health systems. However, according to our survey, 70% of physicians recognize the value of these technologies to improve the care of the patients around the world. Thank you for your attention.
Thank you very much, Pedro, for this important and short presentation. And now it's my pleasure to introduce you Sasha Boveat, who is the Senior International Medical Affairs Manager at Roche, Switzerland. Sasha, the floor is yours.
Thank you, Paola, and thank you very much to the organizers of this meeting for allowing me to join this discussion today. By way of a disclosure, I'm a full-time employee at Roche. So what I'd like to do in the next 5 minutes or so is really outline our vision of how diagnostic innovation can help to optimize a pathway not only to diagnosis but treatment for individuals living with Alzheimer's disease. If I could have the next slide, please. So we've heard already a lot about the World Alzheimer Report, which this year focused on diagnostics. And we all know too well that the diagnostic situation for most individuals is suboptimal. Patients are diagnosed too late. Many people are living with a dementia without a formal diagnosis, as we've already heard. And this report, I think, is really important because it serves to increase our understanding of what the key barriers are to achieving a timely diagnosis. And we've heard quite a lot about this report, thanks to Paola, but I just want to highlight a couple of key areas which I think are relevant for my presentation. And that is that really people living with dementia and the carers report that the key barriers for them, the most significant barriers are lack of access to trained clinicians and a fear of diagnosis itself. From the perspective of clinicians, there's a lack of access to specialized diagnostic tests, but there's also a lack of knowledge in being able to make the diagnosis. And also a significant proportion of people reporting a lack of conviction in the value of giving a diagnosis for the sake of a diagnosis. So I think these are very important barriers that we need to understand and try to address. As we've already heard, we have an increasing number of people seeking a diagnosis, and this is something which is definitely set to increase as we see disease-modifying therapies coming available. ADI maintains that the best practice is a combination of cognitive testing and confirmatory scans or CSF biomarkers. And we've heard a lot about biomarkers from the previous speaker here, so thanks very much for giving us that background. We were particularly pleased to see our Alexis CSF assays being called out in the report to show excellent performance and very low between-day variability, which makes them very suitable for clinical routine use. But for us at Roche, it's not just important that we provide reliable tests. You know, we really want to help to optimize the pathway by breaking down these barriers to achieving a timely diagnosis. And that's why we're particularly interested in analyzing the findings of the report and seeing that where we can help out. And one key area where we are already involved is in medical education. We believe that we have a responsibility to educate clinicians, not just on understanding the clinical value of CSF biomarkers, but also on the value of a timely diagnosis, even in the absence of treatments. So on this next slide, you can see our vision of the optimized patient pathway of the future. And we take a very integrated approach, considering both diagnosis and treatment. And we believe that actually this pathway could be a reality in the next 3 to 5 years. There's been a lot of advances in digital biomarkers over the last few years. And I think one thing that the pandemic has brought us in a positive sense is that we have a lot more confidence now in remote cognitive testing. And being able to for individuals being able to access cognitive tests from their own home, I think really gives a tremendous opportunity for people to be able to take ownership and take some empowerment in maintaining their brain health. It also gives people the chance to be able to monitor the problems that they believe they might be having and to decide whether that warrants further investigation from a healthcare professional or not. So I think digital biomarkers and remote cognitive testing will be very key in the future. Currently, the general practitioner or other primary care physician tends to be the gatekeeper to secondary care. And as such, they have a huge responsibility. They have very little time with individuals. They have a lack of expertise, usually in Alzheimer's disease and other dementias. And they also have a lack of access to quick and sensitive screening tests. So it's a very difficult position that they're in now, making referral decisions. In the future, we've heard already about blood-based biomarkers. You know, we believe a simple blood test could be available for primary care physicians to run alongside the other blood screening tests that they do. And that this, together with a cognitive screening test, could help the clinician to make a very kind of simple decision whether to refer the individual on for further investigation at secondary care or not. And it's not shown on this slide here, but also we're now seeing brain health clinics emerging. And I think that these will be important places where individuals can walk straight in and to get advice about maintaining their brain health, to have maybe a cognitive assessment, or to maybe discuss their risk of developing Alzheimer's disease. So this is an important innovation, I think, to watch in the future. In secondary care, we already have, good technology available to be able to accurately identify amyloid pathology. We've heard already CSF biomarkers and amyloid and tau PET imaging as well. But the challenge is that these are not widely available, and where they are available, they tend to be used more sporadically, maybe for individuals who have an atypical presentation, maybe present young or with an atypical symptomatology. And they don't tend to be used broadly across clinical routine. In some specialist centers, we do see them being used across the board, and there you see, you know, a fantastic optimization of the pathway and individuals receiving a kind of accurate and a timely diagnosis in an efficient manner. So this is something which we hope will improve in the future, and particularly as we see disease-modifying therapies coming onto the market, there is, I think, much more impetus for healthcare professionals to be able to establish amyloid positivity in order to ensure that they identify the right individuals for these treatments as they become available. So we've seen the first anti-amyloid treatment being approved in the US this year. We definitely see more to follow, and we will also probably see some anti-tau agents. And as we have these two major pathologies, it's likely in the future that we will see combination therapies giving us the best opportunity to effectively treat patients. So we really hope that we'll see some trials of a combination of molecules coming through soon. But I mean, really, even in the absence of a disease-modifying therapy, we believe that there is still really very good reasons to identify individuals timely and in an accurate manner. And we've heard already from Paola the importance of being able to have a diagnosis, of being able to have a label for the symptoms that are troubling people. It's important also that people be able to plan for the future, to understand what that future looks like for them, and also to be able to put provision in place, to be able to safeguard against finding themselves in a bad situation where they are not safe and they can't cope. And most importantly, a timely diagnosis is important because it just allows people to maximize the time that they have left before the cognitive deterioration is too significant. They can make time to be with their loved ones. After all, time is the most valuable commodity of all. So with that, I'd like to thank you for your attention, and I'd be happy to take any questions during the Q&A session. Thank you.
Thank you very much, Sasha. I just wanted to remind all participants, if you have questions, please post them into the Q&A. We know that there is somebody that is having difficulty accessing the simultaneous subtitling in 21 languages. I suspect that's probably the German one that you're trying to access. In any case, the team is looking into it, so hopefully you'll be able to access it soon. And now it's my pleasure to cede the floor to Gill Farrar, who is the Global Head of PET Neurology at GE Healthcare in the UK. Gill, the floor is yours. It's a joy to have you with us.
Thank you very much, Paola, and much appreciated. And we can have the next slide, please. Just my disclosure is that I'm a full-time employee at GE Healthcare, and I'm here today to talk to you about PET technology and its role in the diagnosis of dementia. So next slide, please. I don't think I need to remind everyone. I think Pedro did a good introduction in terms of reminding everyone that Alzheimer's disease, it's defined as a continuum, and amyloid and tau at the heart of the pathological heart of the dementia diagnosis, and it ranges from preclinical AD to Alzheimer's disease. If we can have the next slide, please. If I can give an overview briefly of PET technology and amyloid imaging. Number one, the plaques. These are the pathological bodies that you see under the microscope, and these are made of fibrils. Those fibrils are sort of sheets. They're a bit like pages of a book. And the molecules that bind to the fibrils, we can see here Visimil, they're flat planar molecules that sit inside the sheets of the pages of the book like a bookmark. And this is Visimil, you can see, but there is also Neurosec and Amivid that are approved for use as PET tracers. They are radiolabeled with a positron-emitting isotope, and that positron, what happens is, if you can see in number 3, it basically collides with an electron. There's an annihilation reaction, and it releases gamma rays that get picked up by the PET camera. That's in number 4, and basically an image is reconstructed from the signals that come from the PET camera. You can see a negative scan on the left-hand side and a positive scan on the right-hand side. That's then positive for amyloid and negative for amyloid. So if we have the next slide, please. All of the tracers have been validated, and they've had pivotal phase 3 studies where they've been validated against autopsy as the confirmation, and the accuracy was found to be approximately 90%, where basically the scan is either negative or positive. It's compared to pathology, which is either negative or positive. There is also all of the approved amyloid tracers. They use validated reading and image interpretation methodology. For example, you can see this is the reading methodology for Visimil, where we basically use a rainbow color scale. We set the PONs to 90% of the maximum image intensity. And you can see on the right-hand side, the negative scan detail, that's in the frontal lobe, and the positive scan detail, there's a very different pattern when there is amyloid present. If we go to the next slide. One thing that I did want to mention to this group was that it's currently seen that the diagnosis of Alzheimer's disease is frequently incorrect. I've just gathered some evidence here on this slide. On the left-hand side, top left-hand side, you can see a 2012 paper by Tom Beach, where he compared clinical diagnosis to neuropathology as the standard of truth, and the sense and spec was approximately 71%. So there was some misdiagnosis of dementia. In the IDEAS PET study that you can see on the bottom left-hand side, that's Gill Farrar, who was the principal investigator of that study. They had over 11,000 subjects coming into that study. Basically what they showed was basically 25% of the patients who were diagnosed, pre-diagnosed with Alzheimer's before the PET scan, they actually got re-diagnosed to non-Alzheimer's disease. And conversely, 10% of those that were coming into the study with non-Alzheimer's disease actually got re-diagnosed as having Alzheimer's disease. So overall, there was about 35% of those patients that were diagnosed incorrectly before the use of the biomarkers. There's multiple meta-analysis that you can see that have been also published, and they show something very, very similar to the results that came out of IDEA PET. And in the center, I'd just like to show the bapineuzumab study. This is an old anti-amyloid therapy that was being investigated 7 or 8 years ago. And this particular study is of interest because actually of the data that was presented, I think there was about 16% of the subjects had a negative amyloid scan. So they didn't even have the pathology of which the therapy was targeted for, which is very sad indeed. So if we move on to the next slide, it's got a couple more slides. So the future utility, we have seen aducanumab recently approved, and the appropriate use recommendations demonstrate that an amyloid burden is critical. This can be achieved via an amyloid PET or a CSF measure. There are some couple of statements in there that I think do need to be clarified. For example, if the CSF results are ambiguous, then perform a PET test. And then the second one is here, however, if the patient's got an abnormal CSF but a negative PET, then treatment is not recommended. So I still think there's some metrics that need to be worked out. On the right-hand side, you can see that although CSF is performed routinely at centres such as the Karolinska in Sweden, there were 27% of subjects that actually where the CSF results weren't available, there was issues with spinal stenosis or related technical issues, refusal to undergo the procedure, etc., and some analytical issues as well. So I think it is important that from a biomarker perspective that there is a choice, whether it's either CSF or amyloid PET. And then finally, I was asked to present some of the challenges around amyloid PET. That's in the final slide. Yep, so this was a recent survey that came from the Society of Nuclear Medicine in the USA. There was over 350 centres asked. And actually, most of them actually only have one PET scanner on site. And if you look in the bottom, in the blue question at the bottom, question 11, how many additional patients on average could you potentially scan for amyloid PET? And basically, sorry, there's a question that's covering the slide that I'm presenting on the chat. So basically, how many additional patients per day on average could you scan for amyloid brain with no additional hours or staff? Well, there was only an additional 1 or 2 scans that people were saying that they could do in addition to these are the primary oncology scans that they do, even though there's probably capacity. So the rate limiting factors, this is the final statement that I wanted to make for amyloid PET scanning from this Society for Nuclear Medicine survey. I think reimbursement is probably the primary issue. Oncology procedures, routinely, they are reimbursed, and they are 90% of the scan times that take place in nuclear medicine facilities. Tracer access has been mentioned. And there are also staff time, patient preference, and other issues such as patient space in the nuclear medicine department. So that was my brief overview of PET amyloid imaging. So much appreciated, everyone, for giving me the opportunity to talk to you today.
Gill, thank you very much for this really breakneck speed summary of some of the most important things that are around diagnostics today. I can see there is a very healthy Q&A trend developing. There's also a clarification by Sasha Boveat on one of the things that Gill touched on, which is one of the most important in the report, for which I again invite you to read the report, which is the large issue of misdiagnosis, this 30–35% of possible misdiagnosis, and what does it actually mean? Again, for all details, the report will provide you with a lot of information, but also you will have the chance to ask more questions to our speaker, so please keep the questions coming. Now, I am delighted to introduce you to Dr. Emily Largent, the Emanuel and Robert Hart Assistant Professor of Medical Ethics at the University of Pennsylvania Perelman School of Medicine. She is also one of the contributors of the report. Emily, the floor is yours.
Great, thank you so much. So it's lovely to be on a panel like this. People have anticipated a number of points that I'll be raising, which is nice context. And also, I think the comments thus far have really underscored some of the enthusiasm in the field for blood-based biomarkers and what that could mean for both research and clinical care. And so I am looking forward to speaking a bit about what's on the horizon. So the first question we can really ask ourselves is, are we there yet? And I would say that in recent years, researchers have identified numerous very promising blood-based biomarkers for amyloid and tau that can be used to identify Alzheimer's disease neuropathology. But it's very important these tests still need to be validated, and it's important to ensure that they're reliable and that the results are reproducible, particularly in the general population, before we really see widespread adoption. So to answer my own question, the answer is no, we're not quite there yet, but we are getting closer. And as a result, it's a really exciting time for the field because the availability of these tests has the potential to revolutionize care and research. Next slide. So as Pedro pointed out in the beginning, and we've heard in the subsequent presentations, right now the norm really is to use either CSF or PET biomarkers for individuals who are presenting. And of course, these are in higher resource settings primarily. But once they've been validated, blood-based biomarkers really are going to offer numerous advantages. So they are less expensive than CSF and PET. They are safer, less invasive, less burdensome for patients. Certainly they take less time. And blood tests are commonly used in clinical and research settings around the world, meaning that the necessary clinical competencies and infrastructure are already well established. So all of this suggests that blood-based biomarkers would really enhance patients' access to biomarker testing. Moreover, for the reasons I've just outlined, it suggests that there would be serial availability of testing, whereas right now it tends to be much more limited to be able to go back and have those repeated tests. Next slide, please. So now that I've laid out these relative advantages of blood-based biomarkers, I think you can already start to see the potential of these tests, the promise, and why people are so excited about them. And I'm going to highlight just a few of the implications for clinical care here. So as we've already heard throughout this presentation, there are chronic problems of misdiagnoses and delayed diagnoses. And so hopefully having a blood-based biomarker test really would enhance the ability of clinicians, particularly primary care clinicians, to screen patients for Alzheimer's disease. Right now, we know that older adults are often inadequately assessed, and this is due to limitations on clinician time, as well as their lack of confidence or expertise in doing cognitive testing and screening. So hopefully the blood-based biomarker would address these issues and make population-based screening possible. Additionally, it should permit an earlier diagnosis of patients. And even for patients who get a test that comes back and it says that they don't have Alzheimer's disease biomarkers, there's a lot of potential value here because of the differential diagnosis possibilities and the chance to put patients on a path to alternative therapies. The other thing is that we think that blood-based biomarkers could potentially reduce the number of unnecessary referrals for specialty care and scans, which could reduce waiting times and reduce costs associated with screening, although I have some cautions about whether or not they are going to be a net positive for healthcare costs. Additionally, it suggests we can both identify patients who are good candidates for disease-modifying therapy for Alzheimer's disease and hopefully monitor them over time to see if treatment is working. And ultimately, this really holds out the promise of precision medicine for the brain. And that would be an approach to care that takes into account the individual's particular characteristics to identify the treatments that are best for him or for her. Next slide, please. So while I think the field is rightly excited about the advantages that blood-based biomarkers hold, as an ethicist, I have to come in and talk a bit about the ethical, legal, and social considerations in the context in which we have to situate this. So the first question is, we really do need to know what is it that will make community-based practitioners comfortable ordering these tests and disclosing results to patients, making sure they can connect them with care. Right now, as I said, we know that there are issues with confidence in one's ability to do the testing, and so there will need to be support to facilitate the rollout of these. Another question is, we need to think about how we're going to design patient education materials for disclosure of results. There has been extensive study on the effects of gene and biomarker disclosure, but this has been in relatively homogeneous populations in well-resourced countries, and therefore it's necessary to think much more broadly about how to speak about these. A third point is that we already know that Alzheimer's disease has a significant stigma attached to it. It's negative attitudes toward people and discrimination, which is an active behaviors towards people who have Alzheimer's disease and related dementias. And so I have some colleagues at Penn who have done studies showing that individuals, in the general public actually attach stigma to the mere presence of Alzheimer's disease biomarkers, even in the absence of cognitive and functional symptoms. So this suggests that increases in testing could expose individuals to new instances of stigma and discrimination. And this might also be a barrier to people wanting to uptake testing if they're worried that the results could expose them to stigma and discrimination. We need to consider whether or not we have the capacity and resources to care for newly identified patients. I would definitely agree with all of the panelists who have come before that there's value in having a diagnosis and explaining symptoms even in the absence of a disease-modifying therapy. And certainly identifying more patients is a good thing given missed and delayed diagnoses. But we really do have to pair the advent of blood-based biomarkers with renewed commitment to resourcing healthcare systems, because right now, if we were to be able to offer more therapies to people, and certainly there should be supportive services for persons living with dementia, even in the absence of therapies, it's not clear that the healthcare system will be able to absorb all of these individuals. So I would pair the enthusiasm for blood-based biomarkers with an enthusiasm for advocacy to continue making important policy changes. And finally, we have to ask if there will be direct-to-consumer tests. This is probably limited to certain settings where there's already infrastructure for approving direct-to-consumer tests. But much as we've seen direct-to-consumer ApoE, I think we will see direct-to-consumer blood-based biomarkers, which raises its own legal and ethical conundrums. And with that, thank you so much.
Emily, thank you so much for this comprehensive presentation that has really touched the several aspects, from the technical to the ethical and to the big questions that actually are haunting us in policy, especially about capacity, and sort of continue to drive our insistence to government that it's not good enough to say that they're not ready, something has to be done. Because this is just becoming a bigger and bigger issue for everyone. And we'll hear, I'm sure, on this topic more from Kate in a minute. But before we get there, we have Professor Zoe Kourtzi, who is the Professor of Cognitive Computational Neuroscience and an Alan Turing Fellow, which we are delighted to have with us. And we welcome from the bottom of our heart for giving us this fabulous presentation that I have been reading before with great interest. So Zoe, the floor is yours. Give us your point on this.
Thank you very much, Paola, for the kind introduction, and thank you for inviting me. It's a great pleasure to join you, and a great opportunity to hear your feedback on this work, which brings maybe a little bit of a different perspective on what we're discussing so far, looking at how artificial intelligence can actually help us with diagnosis as early as possible and even before symptoms occur. So if I could have the first slide, please. So we heard a lot about challenges in diagnosis of dementia from all the speakers so far. We heard about misdiagnosis and the high risk of that, and how much that affects patients and their families in terms of they have to go down a very prolonged trajectory full of anxiety until they have a diagnosis. The other big challenge that we have in dementia is that we have many different subtypes that may have different causes, and they have different progression prognosis in terms of survival. So how can we address these challenges? If I could have the next slide, please. We propose that artificial intelligence can be really helpful in developing transparent and interoperable algorithms that allow us to make our diagnosis more precise, stratify patients that go into clinical trials in a more precise way, making these clinical trials more cost-effective and developing personalized interventions and treatments from as low cost and as non-invasive data and measurements as possible, that they have lower burden to patients and their families. If I could have the next slide. Just probably you've seen this. What this JAG curve really outlines is that dementia is a progression. It goes from normal brain health all the way to disease. And what you see here is that there are many different, as we've seen, markers based on which we can diagnose dementia. The difficulty is that these markers are more reliable as we progress later in the disease, and especially the less invasive measurements like cognitive tests or wearable data from wearable technologies are not as predictive as we would like them to be very early on. So if I could have the next slide, please. So what we have been doing is building models that come from machine learning. And we train these models with thousands and thousands of cases of patients, thanks to the patients consenting to release their data for research. Now, these models can then act as super well-trained clinicians, and many clinicians that could put their heads together, having seen thousands of cases. And what they actually have the capacity to do is integrate many different data modalities, like we heard about cognitive data and, for example, many different types of biomarker data. These models trained to do very reliable diagnosis and prognosis. And what we strive to do is move away from clinical labels that we know have a high risk of misdiagnosis to modeling individualized trajectories of disease, which are really important for telling us how far an individual is progressing and how quickly they are progressing. If I could have the next slide, please. Just quickly to show you that from the implementation of very simple actually and shallow machine learning models, we get based either on biomarker or on cognitive tests to diagnose whether a patient that has already been diagnosed as mild cognitive impairments or early stages of the disease are going to remain stable or they are going to progress. And what you see in the next slide is that from these models, we can then relate them to future changes in cognition. So we can see that we can extract from this model a kind of what we call a multimodal marker, an index that tells us how far the individual is moving from stable, healthy brain state to disease. If we could move on to the next slide. Now, what these allow us to do is having a machine learning driven marker, which combines many different data types and use this marker to re-stratify patients. There might be patients that are amyloid positive, as we heard, but they do not continue into showing dementia pathology. And the models can tell us whether these patients will remain stable in the future. These patients might not be the ones we want to put in clinical trials, and these patients might not be actually the ones to whom we want to target treatments or further NHS or in general healthcare resources. But there are patients that we can see they are progressing either slowly or rapidly, and that can change the clinical pathways to address the problems of these patients. And you can see this in the next slide. where effectively, after these models are trained, we need much less data. We now have models where we can give, they're already trained, and we can give them from a new patient just a simple MRI scan, 5 minutes of a structural scan, and cognitive tests. And based on this, we can predict whether an individual patient will remain stable or will start progressing, and we can change the clinical pathway in terms of what further diagnostics we need on these patients, and also how quickly we need to put them into the healthcare system, hospitalize and provide any treatments. If I could have the next slide, please. So just to summarize, really, artificial intelligence and machine learning has great potential in integrating many different data type modalities to allow us to define prognostic trajectories in a precise way, to reduce the risk of misdiagnosis, and to facilitate clinical trials that are more precise, that are cost effective, as well as potentially in the future building diagnostic tools for early diagnosis in the context of health checks. So if we could move on to the next slide, this is really the future. We're working with a large project with Alzheimer's Research UK and the Gates Foundation, where we are striving to build diagnostics that can go in early at the stage of health checks, as we heard, in people in their 40s that would never undergo a PET scan or a lumbar puncture, but may be willing to use wearable technologies and have a prediction about their brain health. And I'd like to close. I'm delighted to take questions by thanking everybody who's been working with us. This is a highly cross-disciplinary team. We are working with bringing expertise from computer science and machine learning, but also from clinical aspects and patients. And thank all our funders for supporting our work. Thank you.
Zoe, thank you so much. We had a lot of questions following the first webinar and the publication of the report around how can AI really help diagnostics. And we really needed to hear it from you in larger detail and with this level of helicopter view that really gives us a much broader sense of the level of complexity, but also the how this could seriously ease the diagnostics. I've seen that there are quite a lot of questions coming in, so we are looking forward to that. But now it's my great pleasure to hand over the floor to Kate Swaffer, the CEO and co-founder of Dementia Alliance International, and also a board member of Alzheimer's Disease International from Australia. Kate, the floor is yours.
Thank you, Paola, and thank you, ADI, for the opportunity to speak tonight at this important webinar. Congratulations to the other speakers and also to ADI and the team on producing such a comprehensive World Alzheimer's Report this year. I'm not well equipped to discuss in detail many of the topics discussed by the other speakers tonight, such as biomarkers, amyloid treatments, AI, or other technologies. But I am well equipped to highlight some of the human barriers and perhaps human costs being faced on a daily basis by people with dementia to the current state of affairs with dementia. So I guess with some of these new technologies, we do have to ask ourselves if any of these things will also improve post-diagnostic care or reduce stigma and discrimination. Or will they increase the human costs that people with dementia are facing? When people are seeking a diagnosis, they're too often told their cognitive changes are due to hormonal changes or stress or depression or other conditions with similar symptomology. And the time from someone raising concerns to finally getting referred to a doctor who can make a diagnosis of dementia is still far too long. But unfortunately, once there is a diagnosis, there are many more experiences that are worse than being diagnosed with dementia. People with dementia are systematically still being advised to give up living their pre-diagnosis lives, to get our end-of-life affairs in order, including wills and advanced care directive, and then to get acquainted with community and aged care. That's if it's available in your region or country. And then if it is, navigating the system is almost impossible, even for myself as a past healthcare professional. And there are so few actual services available for people with dementia that we are being left behind in the Sustainable Development Goals. As I've said for more than a decade, dementia is the only condition I know of where people are not supported to live or to fight for their lives. So one might ask, in the context of tonight's webinar, why bother to diagnose anyone with dementia or to diagnose them earlier, particularly if they're pre-symptomatic, when there is almost no post-diagnostic care or support? Innovations in diagnosis and diagnostics are indeed very important, but they do come with potentially some significant human and social risks, many of them perhaps unseen to many people in the audience tonight, but many that are often harmful to people with dementia. One of the biggest challenges I see around the world through the DAI membership is that for those people who've been diagnosed early in the early stages of the disease, is that they are facing a greater disbelief that they have dementia by family and friends, but worse, many eminent medical doctors and researchers doubt their diagnosis and refer to them on social media as not having real dementia. Many people with dementia are also being accused of faking their diagnoses. This is a real human cost of being diagnosed, and also of being diagnosed before you look like you're in the later stages of dementia. So artificial intelligence approaches potentially do pose a great opportunity for individualized pre-symptomatic disease diagnosis, which then plays a key role in the context of personalized, predictive, and hopefully preventive medicine. However, from the perspective of those people diagnosed with dementia, this may increase the incidence of being told we are faking dementia. So the approach may be extremely beneficial for enhancing or improving results in research, for example, in terms of disease-modifying drugs or even a cure, but it may also have a potentially very negative human cost to people diagnosed with dementia. I think that it's important that until everyone changes their attitudes, and for many, what I see is last century views and practices, and supports people with dementia as people with acquired disabilities, and provide disability support and assessment and support straight after a diagnosis. We're being denied opportunities to maintain our independence for longer. The WHO lists dementia as a major cause of disability and dependence globally. And if we ignored something as important as that in any other health space, we'd all be advocating for change. Assessment for all disabilities due to dementia, not only our ADLs or activities of daily living, and proactive disability support is a critical step to help people maintain independence. So whether we're diagnosed earlier or later, everyone with dementia has acquired disabilities and need and have a human right and disability right to that support. So for the more than 55 million people now currently living with dementia, and the more than 40 million people who don't yet have a diagnosis, support for disabilities to improve their well-being and their quality of life, including things such as rehabilitation, is absolutely critical. It's also a legal, moral, and ethical duty of care under the CRPD. We all have the right to a timely diagnosis and for their diagnosis to be believed. We all have the right to be told, if we're diagnosed, that we have dementia, and that's often being denied to many patients due to stigma. Everyone has the right to knowledge and to appropriate care and support, and everyone has the right to be told that dementia causes multiple progressive disabilities. In closing, I would like to pose a question to everyone. Is it ethically or morally appropriate to diagnose people much earlier than when there are any obvious cognitive changes by using AI or these new biomarker methods or any other types of advanced technologies, if it will negatively impact the experience of dementia than is already happening now? Thank you.
Thank you very much, Kate, for this poignant contribution, and also for reminding us of the importance of post-diagnostic support. As we have been discussing ADI, really there should be no point in diagnosing if there is no post-diagnostic support in any case. And I just remind you that next year, World Alzheimer's Report, which is currently already being produced by the McGill team, this time with the leadership of Claire Webster, that spoke at our last webinar, that is going to be an important document that with which this report really cannot exist, as so many people report the cascade of these awful experiences that they go through after a diagnosis. So thanks again, Kate, for this. And I am going now to pass the floor to our last speaker. So next slide, please, Jane. Dr. Linda Sommerlade, who is the head of operation at GT Diagnostics UK, who is going to speak to us about at-home diagnostics. So Linda, the floor is yours for the last intervention of the day, and then the Q&A. Thank you.
Thank you for the introduction and for the opportunity to speak here today. Next slide, please. One of the findings from ADI's Alzheimer's report this year was that there's an estimated 75% of people with dementia who are not diagnosed. If we look at the over 45 population, this equates to 3 people in 500, as you can see in purple on my illustration on the right. Sorry, that's the people diagnosed with dementia, of course. There is then those not diagnosed but living with dementia, shown in blue, which is another 9 out of 500. These are just the tip of the iceberg. Next slide, please. There's another group of people that we have termed the at-risk population, which stems from the fact that there is an estimated 480 million people over 45, which are at BRAC stage 2 or beyond. So this equates to a further 90 out of 500 people who have some sort of change in their brain already that could lead to dementia. If we now consider that new therapeutic breakthroughs are on the horizon and they bring hope to stop or at least slow down disease progression, then in our opinion, the aim should be to diagnose as early as possible to allow those people to then receive treatment once available to preserve quality of life as much as possible. We believe that early diagnosis is about identifying these people that are highlighted in color on this schematic. In addition, those who are at BRAC stage 2, in addition to those who are currently living with dementia but undiagnosed. Next slide, please. Looking at further findings from the ADI report, 33% of clinicians in the survey believe that nothing can be done about dementia, so why bother? They might think about what they as clinicians can do and feel helpless when giving a diagnosis. We believe that knowledge empowers patients to make their own decisions such as those illustrated by Kate earlier. And even if no treatment is available to them yet, they might want to make lifestyle changes or be involved in decisions about their future care. Diagnosing earlier will increase the time for the patients to plan ahead and make those decisions and changes. As the global population ages, the ADI report has shown that 75% of clinicians rank the increasing number of people seeking a diagnosis as a major challenge in the future. We've used here the image of people traveling with a lot of luggage to illustrate that the patient experience from initially suspecting they have dementia to diagnosis can be a confusing and difficult journey. In this image of the person traveling with luggage, a travelator, like the image on the right, would help get them to their destination sooner and easier. For us, this means the process of diagnosing should be streamlined with first steps taken already in the comfort of people's homes. Sasha gave a very nice illustration of this earlier with a very streamlined disease diagnosis process. Sorry. No, sorry, I wasn't finished with that slide. Can you go back, please? I just lost my train of thought. Allowing those who are worried to gain some insight without taking, sorry, I'll go to the bottom of this slide and pick up my line of thought there. So the time pressures and pay-per-visit models for primary care doctors are counterproductive to a complex and sensitive dementia diagnosis. To us, in part, this is due to older tools being used. So the MMSE, for example, was created in 1975 when rotary phones, such as the one in the image, were still in use. More modern tools, just like such as a smartphone, can do so much more than making a phone call. And in that sense, we think that technology should also be used for making a diagnosis, supporting primary care doctors to gather and process information. Next slide, please. The tools that we develop at GT Diagnostics aim to help clinicians make a diagnosis. They don't aim to replace clinicians with technology, but to help them gather information to make their own decision. On the left, the first tool that we have is called Hyper. It is a well-being app that permits the worried well or unwell to monitor their cognitive status at home. So if someone is worried, they can take a first assessment at home. They get a score, not a diagnosis, but they get a score that's compared to a healthy adult population to then know if they should seek further help at their primary care doctor. Hyper Pro is the professional counterpart to Hyper. It is administered as a GEM-like self-administered tool that can be used in the waiting room of a primary care physician, who then gets an output score that has a clinical meaning and can be used as a first step to forming a diagnosis. PsyCox is a specialized neuropsychological testing tool that is based on questionnaire information gathering. In contrast to standard questionnaires, it allows to have a score with error bars already after the first few questions are asked. So if the assessment for some reason has to be ended earlier than expected, there's still an assessment score available. Moreover, our proprietary algorithm allows PsyCox to choose the next question based on the patient's ability, removing the need to ask too easy or too difficult questions and gaining more information in a shorter time. Signex is based on standard EEG analysis. It's an analysis tool of standard EEG data and provides an objective measure of brain connectivity. All of our tools have been developed with the patients not only in mind, but included in this development. We've run several clinical studies. One included over 300 dementia patients and a further 300 healthy age-matched subjects. And this is, in our opinion, very important that these are included in the development, especially if we're talking about self-administered assessments. We need to know if dementia patients can even complete an assessment like that and if it makes sense to them to do so. Next slide, please. Yeah, so I'm just wanting to conclude here saying that people who suspect they have dementia are desperate for a diagnosis. We want to play our part by supporting clinicians to provide accurate and early diagnosis. Thank you for your attention.
Thank you very much, Linda. Very useful to see the array and wealth of possible aids, especially to clinical practitioners. There's been an interesting trend on the chat line, somebody that was saying, why don't you do a next webinar on how to apply all of this in clinical practice? Indeed, this is one of our biggest challenges. This is where all of you on this webinar can be helpful, because the point is that we can prepare and create these wonderful reports, but if they do not end up in the right hands, and this includes the hands of primary care practitioners, then there is no point in doing the reports. On our side, of course, as you know, we will be working and intend to work with national governments to make sure that some of the results of the report end up in the hands of ministries of health, of people that can present some of these techniques to general practitioners, because otherwise, again, there is no point in publishing. So thank you for reminding us of that. Now, where do we start with our Q&A? Because now it's Q&A. So Jane, perhaps you can take away this slide and allow everybody's faces to be seen on the screen. Thank you very much, my fellow panelists. We've had a lot of very positive comments in the chat lines, as you will have seen. Now, I think Kate Swaffer gave us a very important question. So why don't we start with that? I just want to remind you, and probably Pedro can remind us as well, that we have done 2 surveys. One in 2019 when we published the World Alzheimer Report on stigma, and one this year where we've asked specifically to people living with dementia and back then to carers whether it's a good thing to receive a diagnosis or whether they would prefer not to receive a diagnosis. And time again, the public says that they want to know. Everybody wants to know, but there is this ethical question also about timeliness of a diagnosis. ADI will always speak of a timely diagnosis, not of an early diagnosis. And there is a reason for that, of course. But at the same time, some of the new therapeutics coming onto the market requires a diagnosis in the early stages. So there can be a lot of confusion about that. So I would like now to invite Pedro to kickstart that answer, but also I would like Emily to come second, and any of the other panelists that has some contribution, because I think this is an important question. We've got the time. Why don't we speak about it? Pedro.
Thank you so much for the opportunity to answer your question. So what I think it's very important it's about the cover of this, our report. The cover showed invisible. So what clinicians cannot be seen, cannot diagnose with the naked eyes. So we can see a disease process arising in asymptomatic phase of the disease. You do the cognitive test, these people are completely normal. So this opens a unique window of opportunity to prevent dementia. And as soon as we have the therapies for that, I think this test is extremely important. So now I think that the following question is the importance of early diagnosis. So I think there is the asymptomatic phase that is very important, but for patients with mild symptoms, this becomes something important. And the importance of this comes from the implications of the disease. Certain dementing disease, they have a genetic component that has to be explored. There is much more people involved in the family. And also early diagnosis allows people to make decisions. How do they want to manage their life? What will be their future steps, and open a wide range of prospects in terms of how to optimize their time and the decisions that needed to be taken. So for patients who have already touched with symptoms of dementia, they need help actually to generate their finances. I think this is also important because having a diagnosis of the disease, a proper diagnosis, open the opportunity to receive appropriate help and guidance and avoid all the problems that follows from the lack of knowledge about what's going on with their ability to judge and ability to take decisions.
Thank you so much, Pedro. Emily, do you want to come in?
Sure. So, I mean, we've moved earlier to diagnosing people earlier in the course of the disease because there's a thought that's more likely to succeed in effectively preventing the onset of symptoms. I would say my biggest concern with this is really we don't want to leave people who have progressed to mild cognitive impairment or a dementia level of impairment behind just because we're able to treat some individuals. Even if there's a successful disease modifying therapy, there will be people with dementia. There will be people who progress because the therapy doesn't work for them. And it's essential that we don't pit care versus cure. We really do have to think about still creating a lot of care resources for individuals and their families. And not only that, but my hope is that as we diagnose people in the preclinical phase, that we'll actually create really powerful advocates, people who see, not only how they can make changes in their own lives, but how they can advocate for policies that are helpful for themselves and all people who are affected by Alzheimer's disease and related dementias.
Thank you, Emily. Sasha, you want to come in?
Thank you. And thanks to Kate for giving us kind of the stark reality, I guess, of the lack of post-diagnostic support and really forcing us to consider the other side of it. I mean, I would agree, Paola, it's really about a timely diagnosis. I'm not an advocate of early diagnosis. We do have the technology now where we can detect the pathological changes pre-symptomatic. And I think that's useful for research purposes, but not in clinical practice. I do think that there's an individual and a personalized element here. People have the right to make the choice for themselves as to, at what stage they receive the information and receive the diagnosis. And for some people that will be earlier, and for some people that will be later. So I think it's considering what's right for the individual in their particular situation, making the tests available for those who want to, explore their cognitive deficits earlier. But also ensuring that you tackle these issues around post-diagnostic support. And I think, importantly, this issue of stigma, hopefully as we move more towards a biological definition of Alzheimer's disease, we're starting to tackle some of the issues around stigma as well. So I'll stop now and leave some time for Gill to come in.
No, I was just going to mention what you said about an early diagnosis, and maybe Pedro could comment. One of the things I'm very interested in is not only issue in terms of the therapeutic treatments, but sort of maintaining cognitive reserve and strategies such as sleep health, diabetic health, diet, lifestyle, and the importance of those sort of strategies in staving off and enabling a subject to maintain cognitive reserve. Pedro, I'm not sure if you've got any studies ongoing, but I know there's studies like the finger study, the Finnish study, the lifestyle studies that are very important as well. And I think visibility around those studies is critical as well.
Thank you very much. I'm going to stop this question here, although I'd like to hear from Kate briefly whether she thinks that this has been an interesting set of replies. Before I do that, I just would like to remind everybody that there is plenty of resources on our YouTube channel. We did several webinars on risk reduction prevention of the finger studies. What Gill is mentioning, there's plenty of studies around the world that look at risk reduction, which is of course a very important issue we've dealt with elsewhere. Now, Kate, would you like to come in? Because I've got a second question that I want to go to Zoe.
Yeah, I will just respond briefly. And I think that if we change our thinking a little bit about dementia just being a disease where we're all going to deteriorate and lose who we are, and start to manage it like a chronic disease. If you're pre-diabetic, it's really good to know about that. So you have the opportunity to change your lifestyle, to improve your diet, to get back, if you've, like I'd been, typical busy working mother, hadn't exercised enough, was a bit overweight, and watching a program by Dr. Michael Mosley the other night, you don't have to be very overweight to be pre-diabetic. So surely these same sorts of strategies could be applied to people with very early stage dementia, even pre-symptom dementia. But of course, like all chronic diseases, not everybody is interested in, managing a lifestyle approach, because it's quite hard work to be disciplined. But, personally, I would like to know, and I was one of the lucky few to receive a diagnosis easily in the very early stages, but many other people, especially younger people, can take 5-7 years to get their local doctor to take them seriously enough to send them to a specialist.
Thank you very much, Kate. Now, there is another strand that is in the question and answer, and I'd like Zoe to come on it first and then Linda. Broadly, Artisha asks, how much of this fantastic R&D is taking place in the global south, and how can we increase this? And Yvonne Martins asks, and an anonymous attendee asks, what extremely cost-effective methods are being developed for accurate diagnosis that can be used in a third world country like Uganda? So, as you know, ADI is about equality at very many levels, but one of them, and one of the prompts for this report was, okay, so we think in higher income country we got diagnostics right, and actually we discovered it's not true. But in lower income countries, the situation is even worse. There are no diagnostic tools. There are not even the specialists that could interpret those diagnostic tools. So how are we going to achieve a little bit more equity? And Zoe and Linda gave us some answers in a way in some tools that could be used perhaps by everybody, that don't perhaps require some of these machinery. So Zoe first, Linda after, could you tell us a bit more about how your discoveries could be applied to the Global South?
Yes, sure, great. Thank you, Paola. That's a really interesting question. It's really, when we talk about, from the side of AI, it's really about reducing these inequalities in health. We have a long way to go to be able to achieve this. How good our tools are to address the global challenge of dementia really depends on how much data we have across many different countries from patients that have very different demographics, very different genetics. The power of the algorithms is really that they can learn all of these patterns and can generalize them, but this is a real challenge. So this is something that computational scientists are really facing, and it's at the forefront of developments in AI. How do we achieve this generalizability so that when we develop these powerful algorithms to a state that they can reliably predict, they can actually generalize across demographics and across populations. From the side of the tools we have for collecting information, data about the patients that allow us then to diagnose early, a lot of wearable technologies are definitely the future in terms of this is something that is portable. We don't need to bring people in for scans, for brain scans or for lung punctures. So with cognitive testing, with apps, with wearable data like measuring physiology or even brain activity like an EEG, a portable EEG system, we could have really great success in moving diagnosis earlier in countries where the kind of advanced healthcare technologies are not available. And interestingly, there is recent developments on even on portable MRI scanners. And I think this is really exciting. And again, AI here has a big role to play. We know that from as the devices become, if you want, more less invasive, the data quality is not going to be as detailed, as precise. However, what we can achieve with machine learning algorithms is to map between data that comes from highly costly but very detailed images with data that comes from less invasive, less costly portable devices, and make these kind of latter data as predictive as the former. So really there's a lot we can do with technology if used appropriately to bridge this gap and reduce the inequalities.
Thank you very much, Zoe. Linda, you've got about 30 seconds.
Okay, I'll try to be quick. We are developing one of our tools called Signex is based on EEG data, so that could be a cost-effective imaging alternative to more expensive imaging tools. Also, for example, our HiPod tool is based on images of objects that can easily be adjusted to other cultures by exchanging the images to things that people see in their everyday life, to then assess with the same tool people from a different cultural background and easily transfer the results to the results we already have and the research data we have.
Thank you very much, Linda. That's really interesting. And I hope that those that are listening that are coming from countries where some of these is not available yet do take hope on the fact that some of these innovation will be portable. Now, there is a lot going on still in the Q&A and the chat line, especially of people living with dementia, telling of their testimony about early, timely diagnosis, which I encourage you to read. Some of the specific questions, especially addressed to Gill, there were a lot that were addressed to you in particular, have not been answered. I've tried to pick up those that were more of general interest, but we will try and answer those people that had the questions afterwards. As I can remind you, this webinar is going to be available online on YouTube within 24 hours. I do thank, as ever, my fellow panelists who have been fantastic and their wonderful contribution, but I also thank, as ever, my fantastic team without which this webinar would not be possible. I also thank all of you that have come and participated. That were over 270 at some point, and then I lost count. And many are commenting of the fact that it's wonderful that we can now provide automatic subtitling. That's definitely convincing more of you in countries with languages that are not English to participate, which is great. I also want to thank all of you that woke up very early in the morning or went to bed very late at night to be with us live tonight. So thank you very much, and I look forward to seeing you for our next webinar. Thank you. Goodbye.